Hey guys, I hope I'm audible. Hi, hi, Dr. Prithvesh, how are you? Good evening, good evening. Hi, Dr. Adi, hi, Sana, how are you? Thank you so much, thank you so much. Thank you so much for joining for today's session. So, this is, as we all know, this is an IBQ, like image-based question, a sprint, which we launched it from DocTutorials. I hope is going to be very much useful. And we expect at least like 20 to 30 percentage question conversion rate from this sprint which we're actually doing, because we used to work a lot, especially for this particular sprint which we have planned. Good evening, everyone. Yes, I'm facing a question like, an FMG can watch it? Yes, yes, of course, because all this is going to be useful for every set of people. Yes, buddy. Yes, buddy. So we'll start with the first question. Voice is not clear. Okay. Just give me a minute. What about now? I don't know what's the issue. Just give me a few minutes back. Just give me 2 minutes. Sorry guys, just give me 2 minutes. I think the issue will be sorted out in 2 minutes. Sorry for that. What about now? What about now? Is the image and my voice clear, buddy? Thank you, Jahangir. Thank you, KK. Thank you, Mitalish. Thank you, Bhuvna. Thank you so much. Thank you so much, buddy. So we'll start the session. Without any further delay. So with this, as we can see in this first image, this is typically a type of peripheral neuropathy, buddy. This is a type of peripheral neuropathy. And what type of peripheral neuropathy is this? Very much clear and very much direct, right? We have two different areas in the body, hand and foot. So what type of peripheral neuropathy is this? Very much direct question, buddy. I have started with a very slow and a very direct question here. Yep, guys, come on, quick. What type of peripheral neuropathy is this? Yes, exactly. Thank you so much. This is what we call as hand and foot syndrome. Peripheral neuropathy, glove and stocking, Trinath, yes, the answer is right, but the point is we are going to be discussing it for the next question. The answer is right for the next question. For this question is going to be hand and foot syndrome. See, as per peripheral neuropathy is concerned, we have many different subtypes which might be manifesting as just muscle weakness, or it might be manifesting as the hand part and the foot part alone. This is called as hand and foot syndrome. Hand-foot, Dr. Adi, I think hand-foot-mouth disease is an infectious disease which is commonly seen in children, but this is not a type of that. This is peripheral neuropathy, hand and foot syndrome, which can be seen with which drug? It can be seen with, remember this, whenever we talk about hand and foot syndrome, remember I am going to be writing up CPD over here. Just remember that I'm having my hand here, I'm going to be writing CPD over here, which means C, P and D. 5 stands for 5-fluorouracil. 5 stands for 5-fluorouracil. Number 2, C stands for capecitabine. C stands for capecitabine. Number 3, P stands for pemetrexed. And D stands for doxorubicin. Remember, with this mnemonic, very easy mnemonic, but we are facing many different questions, especially from this topic, buddy. Which drugs are associated with hand and foot syndrome? Hand and foot syndrome is a type of peripheral neuropathy. It can be seen with, remember, 5 fingers, and I'm going to be writing up CPD over here, which means 5-fluorouracil, capecitabine, pemetrexed and doxorubicin. All these drugs are associated with this. Yes, doctors, I'm getting answers like amiodarone, you're right, it produces peripheral neuropathy, but this peripheral neuropathy will be manifesting as peripheral muscle weakness, especially proximal muscle weakness. I hope my screen is visible. No. What is happening? Guys, just give me like 5 minutes, I'll just connect it back. Just give me 5 minutes, I'll connect it back. Yes. Guys, am I audible now? Okay. The screen is visible and am I audible now? Yes, yes. Yes, thank you so much. And what about now? Audio is not clear? Yes, yes, yeah. Thank you, thank you. Sorry for that, guys. It's just a small connective issue with my iPad and Surface Pro. We know the issue between Apple and Windows. Both of these guys doesn't like each other, so there's always some issue which usually happens. Uh, but anyhow, we'll start with the we'll proceed with the session, buddy. So we were talking about the drugs which might be producing hand and foot syndrome. We have five different. We have 5-fluorouracil, capecitabine, pemetrexed, and doxorubicin. We'll move to the next image now. Yes, how can you guess how many can guess this the answer for this image, buddy? Yes, so this is a similar concept which we have dealt with regarding your hand and foot syndrome, but this concept is not purely for hand and foot area. We can see the peripheral neuropathy. We can see the peripheral neuropathy which has been developed in both the dorsum and also in the anterior parts. So simply put, we can call them as stocking and glove neuropathy. This is called as stocking and glove distribution of neuropathic pain. This is stocking and glove neuropathy, guys. This is what the answer which I was explaining previously, like the answer was given by Dr. Jahangir and like many other of you who have given the answer for this stocking and glove neuropathy, which is actually seen with taxanes. See, this kind of stocking and glove neuropathy explains it's a simple concept. Whenever the palm or when the hand alone is going to be involved, it will be named as hand and foot syndrome, the type of peripheral neuropathy. But when this area also the dorsum also is going to be involved, both this part and that part is going to be involved. Similarly, stocking distribution is going to be seen till your hip region. Those kind of neuropathy is classically seen with taxanes. Remember, these two adverse drug reactions are very, very important, guys, because recently in the national institutes, which inclusive of AIIMS, we have seen lots of studies which has been conducted, especially in relationship with taxanes and its association with peripheral neuropathy, and that is stocking and glove neuropathy. So also remember that we have hand and foot syndrome, right? Hand and foot syndrome is produced because of 5-fluorouracil, capecitabine, pemetrexed, and doxorubicin. Also, one more point, remember 5-fluorouracil, we have remembered that hand and foot syndrome. This is the mnemonic, remember that. 5-fluorouracil, hand and foot syndrome. Also remember that 5-fluorouracil produces cardiotoxicity. 5-fluorouracil produces cardiotoxicity. This is again one more mnemonic, remember how 5-fluorouracil can produce hand and foot syndrome and cardiotoxicity. Here we have taxanes which might induce stocking and glove neuropathy. Both these types of neuropathies can be resolved if the dose of the drug is getting reduced. And one more point, even if you reduce the drug dose, if you want to treat the patient, we can opt for vitamin B12 injections, and also if in case we can give steroids also. These are the treatment process for peripheral neuropathy due to all these different drugs. We'll move on to the next one. Yeah, so this is, we can see muscle wasting, guys. This is clearly muscle wasting which has been pointed up over here. So why is there a muscle wasting? Because of long-lasting carpal tunnel syndrome. Because of a long-term carpal tunnel syndrome. Now the question comes, which drug tend to produce carpal tunnel syndrome? Yes, buddy. Anyone who can give the answer for this question? Which is the drug which might induce or worsen carpal tunnel syndrome? Yes, I'm waiting for the answers, buddy. Try to guess out some questions. Very important, buddy, because again, this is a recent update which study has been done in many different institutes, and it has been a clear-cut proof. Even though it has been done, the study has been done long before, and the relationship has been proven long before. It has been a recent past. Like majority of the questions is being asked from that. A drug which might induce carpal tunnel syndrome. Anyone? I will give you one clue, buddy. I will give you one clue. Your transverse carpal ligament, your TCL, no? Your transverse carpal ligament contains estrogen receptors. Your transverse carpal ligament contains estrogen receptors. Dr. Trinath, zinc alkaloids, nobody, zinc alkaloids is not associated with carpal tunnel syndrome. Might be a rare case, but it is not usually associated with that. Any other guesses, buddy? Any other guesses from any of the other students here? Your transverse carpal ligament contains estrogen receptor. Yes, buddy, come on, think of it. I will given you the first clue, right? It contains estrogen receptor, which means tamoxifen. Good guess, Dr. Meet Patel. Thank you so much. Your guess is good, but you are somewhat related with that. But the answer for that is, of course, you have got that concept of estrogen receptor and carpal tunnel syndrome. Oral contraceptive pills are associated with carpal tunnel syndrome. Oral contraceptive pills are associated with carpal tunnel syndrome. An important image, buddy. Letrozole, yes, it is also can be used for that. Letrozole is a long-acting drug. Oral contraceptive pill can be associated with carpal tunnel syndrome. Remember this, buddy. Oral contraceptive pill. OCP, we know that it's going to be oral contraceptive pill. But pharmacologists, we prefer to call them as two different terminologies. Oral carpal pill, which means oral contraceptive pill are associated with carpal tunnel syndrome. Also, oral coagulative pill, which means all the OCPs are also associated with thromboembolism. So instead of calling it as oral contraceptive pill, of course that is the original name, guys, I don't want to change it. But oral, if you just want to call it as oral carpal pill or oral coagulative pill, you will understand one more adverse drug reactions of those. Carpal tunnel syndrome and coagulation, that is thromboembolism, are associated with oral contraceptive pill. Please remember that. Yes, what exactly is this? First of all, my question is, what part of the body is this? This is head, buddy. This is head. Anyone can guess. This is an original case report which has been published. Now try to answer this question. What exactly is this case? It is a drug-induced adverse drug reaction. It is a baby's scalp. We have loss of skin development in scalp. I'm repeating those sentences. Loss of skin development in the scalp. This is seen with which drug? This is seen with which drug? You just come up with some answers, and after that I will just give you some more clues for that, buddy. Yes, guys, come on. Yep, good, Dr. Chandani, you're right. Carbimazole, beautiful. You have come up with the correct answer here. The answer is, this is a case of aplasia cutis. This is a case of aplasia cutis congenita. Aplasia cutis congenita. Exactly, Dr. Trinath Mishra. Aplasia cutis is the right answer. This is aplasia cutis congenita, which is typically seen with carbimazole. What exactly is carbimazole? Carbimazole is an anti-thyroid drug which is used for hyperthyroidism. We also have a methimazole, but currently we use carbimazole. Carbimazole is a prodrug, buddy. Carbimazole is a prodrug. It is converted to methimazole. See, as per Dr. Neha, you're right. Target NEET PG 2024. I love that name, buddy. Carbimazole, you're right. See, this carbimazole and also methimazole, it tend to produce whenever it is given in pregnancy, especially when given in first trimester in pregnancy. we can expect a triad of your teratogenic adverse drug reactions. We can expect a triad. First one, it is associated with aplasia cutis, loss of skin development in the scalp. Number one. Number two, it might be producing fetal goiter. It might be producing fetal goiter. And number three, the patients or the babies might develop choanal or esophageal atresia. Choanal or esophageal atresia. These are the triads of adverse drug reactions which is seen when a patient is treated with carbimazole or methimazole in the first trimester. And that is also one of the reasons why, as Dr. Chandani is also explaining, propylthiouracil is safer to be given in first trimester of pregnancy. So what is the drug of choice? First trimester of pregnancy, buddy? What's the drug of choice in first trimester of pregnancy? Propylthiouracil. In second or in third trimester, because the development has been completed, then we opt for carbimazole. Why are we opting for carbimazole? Because I will give you two major differences between propylthiouracil and carbimazole, guys. Let's talk about propylthiouracil and carbimazole. What are the primary differences between these two? Point number one, which drug is going to be more potent? Is it carbimazole or propylthiouracil? Carbimazole is more potent. Carbimazole is more potent. Propylthiouracil is comparatively less potent agent. Point number one. Point number two, which drug has got superb Dr. Aiza, Dr. Aisha, Dr. Jays, you're all right. The answer is going to be propylthiouracil. So which drug is going to be safer to be, as of course we know, which drug is safer to be given in pregnancy? Propylthiouracil is safer to be given. This drug is contraindicated. This drug is contraindicated. Now the third point, which drug is associated with additional peripheral deiodinase inhibition? Additional peripheral 5-deiodinase inhibition, guys. I will wait for the answers from you all. Additional inhibition of 5-deiodinase or peripheral conversion of T4 to T3 is also inhibited by one important drug. Is it propylthiouracil or carbimazole, buddy? Yes. Come on, guys. If we have thought propylthiouracil is the potent agent, no, guys. Dr. Neha, you are right. Dr. Neha, you're all right. Very good, guys. Very much happy. Propylthiouracil has got additional peripheral 5-deiodinase inhibitory property. 5-deiodinase inhibitory property, and that is not seen with carbimazole. You're all right. Now comes the next question. Which drug is associated with maximum agranulocytosis? Which drug is associated with the maximum agranulocytosis? I will wait for the answer, buddies. Which drug produces maximum agranulocytosis, guys? Yes, come up with the answers here. Is it propylthiouracil or carbimazole? A very important adverse drug effect. Which drug produces agranulocytosis? Beautiful, very good. Oh my god, I'm getting mixed reactions. Mixed reactions, we're getting a mixed answers here. Some saying propylthiouracil and some saying carbimazole. Carbimazole. I'm getting 4 or 5 carbimazole. See, I'll just clear that concept here, buddy. The drug which is associated with maximum agranulocytosis is propylthiouracil. Maximum agranulocytosis is propylthiouracil. This produces minimum agranulocytosis. Compared to propylthiouracil, the incidence of agranulocytosis is going to be lesser. Yes, Dr. Target NEET PG 2024, you are right. Of course, agranulocytosis we always think of clozapine. But here, as compared to propylthiouracil and carbimazole, we come up with the answer that propylthiouracil produces maximum agranulocytosis. Now comes the next important question. If for the first trimester we prefer to give propylthiouracil, why can't we continue propylthiouracil for second and third trimesters? Why can't we continue propylthiouracil for second and third trimesters? Why we need to change the drug to carbimazole? Point number one, carbimazole is more potent. Yes, of course. But we have one more point, buddy. Propylthiouracil carries a serious risk of hepatotoxicity. Serious risk of hepatotoxicity, which is very much more with propylthiouracil as compared to carbimazole, which produces minimum hepatotoxicity. And this is the reason why propylthiouracil is preferred only for first trimester and carbimazole, methimazole are preferred for the second and third trimesters. So we have derived many different points from this areas, buddy. Remember this, aplasia cutis. Aplasia cutis, we are going to be talking about carbimazole. We'll go to the next image. Which drug produces this? This is like a red lesion which has been there on the trunk. A red colored lesion which is present in the trunk. Yes, doctor, I'm waiting for the answers. Red colored lesions. What is the second point? Actually, it is there, buddy. Of course, the videos, it will be there in the videos itself. So once the class is over, you can just go back and take a look at it. Yep, this is a red colored lesion on the trunk. Anyone? Which drug produces red colored lesion? I will also give you one more clue, guys. Red man syndrome. Which drug is associated with red man syndrome? Yep. Carbamazepine, yes, there is a possibility of production of red man syndrome, but most importantly, the only drug which is directly associated with red man syndrome is going to be vancomycin. This is vancomycin, guys. Please note that India has reported teicoplanin. Yep, you're all right. Vancomycin, beautiful answers, buddy. Please note that not only vancomycin, even teicoplanin is associated with red man syndrome. I don't know whether I'm fortunate enough or sorry to spill the beans, that this terminology is currently not being used. There is no red man syndrome. It has been changed recently to red person syndrome because it is also seen with male and female. So the name has been changed to red person syndrome, but even after that, we don't use that red person syndrome also. The current nomenclature is vancomycin infusion reactions, VIR. The current nomenclature is VIR, vancomycin infusion reactions. These vancomycin infusion reactions, how can be? The question is, how can it be prevented? The question is, how can it be prevented? Vancomycin infusion reactions can be prevented by administering vancomycin as slow IV, buddy. It is administered as slow IV. By administering it as slow IV, I can prevent the development of red person syndrome, vancomycin infusion reactions. Also, I can give prophylactically, it can treat the patient prophylactically with diphenhydramine. Diphenhydramine, here we are using it as an antihistaminic agent. And also we have to give it along with famotidine. Because it is also an antihistaminic agent. What's the difference between diphenhydramine and famotidine, guys? Try to answer this question. What's the difference between diphenhydramine and famotidine? Diphenhydramine, both are antihistaminic agents. But what's the difference between these two? Anyone? Antihistamine, diphenhydramine. Yes, Dr. Suresh, you are right. Very good. Antihistaminic drug is your diphenhydramine, but famotidine also is an antihistaminic agent. Yep, you're beautiful. The answer is exact. Diphenhydramine is a H1 blocker, whereas famotidine is a H2 blocker. Yep, exactly. Famotidine is a H2 blocker. So current recommendation is, when a patient is more prone to land up in vancomycin infusion related reactions, if he has presented previously, like previous history of vancomycin infusion related reactions, and now we have to administer vancomycin. In those conditions, I have to treat the patient prophylactically with a H1 blocker in combination with H2 blocker, and the theory says that vancomycin infusion reactions is not only because of H1 receptors, it is also because of H2 receptors. Understood, guys? So, what's the treatment option? Diphenhydramine in combination with famotidine. Slow IV also can prevent development of vancomycin infusion reaction. Fantastic, guys. So I'm just trying to make sure as much as possible, because we're not just discussing the images, guys. I'm just going to be giving you the treatment for that conditions also. So what exactly is this condition? What exactly is this conditions? I will give you one more clue, and this is what exactly is this condition, buddy? I have given you the classical diagram also. Don't expect this diagram to be drawn in your main exams. Yeah, I'm getting the question. Is it treatment or prophylactic measure? It's a prophylactic measure, buddy. Even for treatment, I can use the same set of drugs. Even for treatment, I can give H1 blocker and H2 blocker. If in case the issue is progressing further, I can opt for steroids also. The concept is I have to treat the inflammation. That's the process there. Yep, even before explaining that, the answer is, you're flooding with the answers, guys. Thank you so much. Bullseye retinopathy, which is seen with which drug? Option A, chloroquine. Option B, hydroxychloroquine. Now, this is what a question is. Yep, guys. What exactly is the answer? Which drug produces that? Is it chloroquine or hydroxychloroquine? Which drug will produce this? If you want to choose one drug out of both, which one will you choose? Macular edema, chloroquine. Good. Chloroquine is associated with the macular lesions. Here it is going to be a bullseye retinopathy. Here it is called as bullseye retinopathy. Srinath, you have answered for both, and Dr. KK had answered for both, and all the others you are coming up with chloroquine. Actually, to say all of you are right, both the drugs chloroquine and hydroxychloroquine will produce this bullseye retinopathy, but as the question goes, which of the following drugs tend to produce bullseye retinopathy? Option A is chloroquine, option B is hydroxychloroquine. If you want to choose one drug out of those, you have to choose hydroxychloroquine more than chloroquine. Hydroxychloroquine more than chloroquine. You know why? Because it's a very simple concept. Chloroquine maximum drug dose commonly used is not more than 3 days. Clear? But hydroxychloroquine, the patients will be under therapy with hydroxychloroquine for a very long time, especially for rheumatoid arthritis and many other related conditions. That's the reason bullseye retinopathy will be evident more commonly with hydroxychloroquine than with chloroquine. Even though both the drugs has the tendency to produce that, statistically speaking, incidental rate tend to say hydroxychloroquine produces maximum bullseye retinopathy. Beautiful concept, right? Good. We will move on to the next image, buddy. Of course, this is what one of the questions which, yes, Dr. Suresh, you told rheumatoid arthritis, you're right. This is what we used to explain it as macular edema. This is macular edema. Here we can see pockets to be there below that. This is a normal segment, and here is where pockets can be seen. And which is seen with? So I'm facing a question here. What is the difference between two and of clinical use? Chloroquine is actually used for malaria and many other conditions. So as you have put up that question, I'm facing a question here, like what are the clinical uses of those things? Understand, guys, the uses of chloroquine. The uses of chloroquine, we have a mnemonic. Remember the uses of chloroquine. Remember with this mnemonic, rest in peace, MLA. Please don't take it personally. This is just a mnemonic. Rest in peace, MLA. R stands for chloroquine can be used for rheumatoid arthritis. I stands for infectious mononucleosis. Infectious mononucleosis. P stands for porphyria cutanea tarda. Porphyria cutanea tarda. M stands for malaria, which is currently being used. Chloroquine is currently maximum used for malaria body. But of course only for Plasmodium vivax or ovale, because majority of the falciparum is currently being resistant. L stands for lupus erythematosus. L stands for lupus erythematosus, yes. A stands for amoebiasis. A stands for amoebiasis or systemic amoebicidal agent. Systemic amoebiasis, I can use malaria. I can use chloroquine. So simply as the question is been put, what's the clinical use of chloroquine? This is the clinical use of chloroquine, guys. Hydroxychloroquine, it has been used previously for many different conditions, but currently it has been preferred mostly for rheumatoid arthritis alone. Good. Now, let's move back to this point, guys. Macular edema, which is seen with, I will give you one important clue. One anti-glaucoma drug tend to produce that. Anyone? Drug used for glaucoma is associated with macular edema. Anyone, buddies? Anyone? Come on. I will also give you the second clue, open angle glaucoma. I will also give you the second clue, open angle glaucoma. Yep, anyone? Open angle glaucoma for one important drug which is used for open angle glaucoma, I can use this. Fantastic, I'm getting the answers. Latanoprost. Carboprost, we don't actually use that, buddy. I'm getting astazolamide, PGF2 alpha, you're right. Astazolamide, nobody. Astazolamide is not associated with the macular edema because moreover it's a diuretic agent. I think it has got least chances to produce an edema. Of course, you understand the logic behind that. The drug which is associated with the macular edema is going to be latanoprost. Latanoprost, especially all these drugs are PGF2 alpha analog agents. These are PGF2 alpha analog agents like latanoprost, bimatoprost, and other set of drugs like tafluprost, many drugs. But carboprost, usually it's not been included here because carboprost is more of a drug used for postpartum hemorrhage, buddy. It is currently not used directly for your glaucoma, buddy. So as per your PGF2 alpha analog is concerned, it has got certain set of adverse drug reactions. Number one, it might produce iris pigmentation. It might produce iris pigmentation, PGF2 alpha analogs. Number two, it is also associated with hypertrichosis. It is also associated with hypertrichosis and most importantly, macular edema. Most importantly, macular edema. Please note that macular edema is not only produced by this. Macular edema is also produced by one more anti-diabetic drug called as thiazolidinediones. Name some thiazolidinediones which you know, buddy. Yes, astazolamide is given orally in glaucoma. Yes, guys, is given orally in glaucoma. Heterochrome iridis, very good. Yes, that's what iris pigmentation is. It might produce altered iris discoloration, and that's why most commonly it is given as bilaterally in both the eyes. Name some thiazolidinediones which you know. Name some thiazolidinediones. Drug name, buddy. Thiazolidinediones. Anyone? It's an anti-diabetic drug. Fantastic. Yes, I'm getting the answers. Anyone else who can come up with the same answers? Yep. Thank you so much. Reactivation of herpes. Yes, that's a possibility of your latanoprost, buddy. But here we are talking about thiazolidinediones, exactly glitazone agents. Pioglitazone, rosiglitazone. Pioglitazone, rosiglitazone. Even though the chance of development of macular edema is going to be very much weak, there is a possibility of macular edema. And one more important question is there, buddy. If a patient is under therapy with thiazolidinediones like pioglitazone, and if the patient develops macular edema, what's the next step in management? We can't decrease the drug dose. Remember, we have to discontinue the therapy. If an option comes to like decrease the drug dose, don't do that. That's not going to be there. Macular edema is a rare adverse effect of pioglitazone which warrants immediate stoppage of therapy. I have to change the patient to one more newer drug, guys. Beautiful. We'll move to the next image. This is a black discoloration in the fingers. Remember, this is a black discoloration in the tip of a finger. Pyopancreatitis, good, nice mnemonic body. But if you ask me about which drug is associated with more pancreatitis, I will opt for GLP-1 analogs. GLP-1 analogs like exenatide, liraglutide, semaglutide, those drug produces maximum pancreatitis compared to these drugs. Good. Black pigmentation in the fingers. Yep, anyone? Tip of the fingers, guys. Which drug is associated with that? That's the problem. I'm getting the answers like warfarin. Calcium channel blockers, mostly it will not be producing that because calcium channel blockers are arteriolar dilator agents. It will not produce black discoloration on the tip body. Warfarin, getting many answers as warfarin. Purple toe syndrome, see, that's the question. That's why I'm going to be repeating that again. The concept is black discoloration on the tip of the fingers, not in the toes. Purple toe syndrome is different, and the black discoloration which is present in the fingers is going to be different. This is not purple color, this is black colored pigmentation. Remember that. This is not purple colored discoloration, this is black discoloration. See, that's why there is more chance of it to land up in that. Don't worry, majority of you used to do that mistake. I am here to clear that, don't worry. See, black discoloration. Black discoloration on the tip of the fingers is due to ergot alkaloids, buddy. Is due to ergot alkaloids, remember that. This is ergot induced. Yes, Dr. Pradesh, you are right. Calcium channel blockers are actually used for that. Black discoloration is nothing but ergot alkaloids which induces gangrene. Peripheral artery vasospasm. It is associated with the peripheral artery vasospasm which might produce gangrene. Which might be associated with the gangrene. You are right, buddy. Now I hope you can understand what's the difference between that. So because warfarin induced purple toe syndrome is a recent question, like previous year question. If you land up in these kind of images, there is more chance of it to land up with warfarin. Please don't fall into that trap. You think of where exactly is that discoloration, what exactly is that color. If the color is going to be black in color, it's because of lack of blood supply, because of extensive arterial constriction. No blood supply is happening. Because of it, super added gangrene tend to occur. What's the treatment option? How can we treat this peripheral artery vasospasm due to ergot alkaloids, buddy? Non-selective beta blockers, yes, that also produces peripheral artery vasospasm, you're right. Non-selective beta blockers is also associated with the vasospasm. But here, what's the treatment of this black color discoloration or gangrene to be developed? We have to give sodium nitroprusside. Sodium nitroprusside. One more question. Why sodium nitroprusside is preferred than nitrates? Because sodium nitroprussides are more of arteriolar dilator than a venodilator. Here, the issue is arteriolar constriction, guys. I have to give an arteriolar dilator. Simple one. That's it about your black discoloration of tip of the fingers. Which drug is associated with this? A very famous question. Which drug is associated with this? What exactly is this? Yes, guys, you're all right. Vasodilators, nitroprusside, very good, you're all right. But little bit change in that terminology. Instead of using the terminology vasodilator, use arteriolar dilator. That will, you will understand it still more further, buddy. So which drug is associated with this? Yep, waiting for the answers. Waiting for the answers. You couldn't find out what exactly is this? This is, we used to call them as MRONJ. We used to call them as MRONJ. What is MRONJ? Beautiful, Hari, you're right. Medication related osteonecrosis of jaw. This is medication related osteonecrosis of jaw. Not gum hypertrophy, buddy. Here we can't see gum hypertrophy here. The concentration is, we can see the jaw bones which is present. Yep. So this is typically a case of medication-related osteonecrosis of jaw, which is seen with which drug, buddy? Of course, majority of you have answered that question again. Bisphosphonates are associated with this. Which bisphosphonates are associated with this? Is it peroral or parenteral? One more additional important point. Yep. The answer is bisphosphonates, buddy. See, bisphosphonates, especially parenteral bisphosphonates, tend to produce maximum osteonecrosis of jaw. Peroral bisphosphonates tend to have less chances of it. What are the parenteral bisphosphonates? Again, we have only two drugs at present, pamidronate, and what is that one other drug which is a parenteral bisphosphonate, buddy? Yep, right, you're all right. Thank you so much for coming up with these answers. Pamidronate is a pamidronate is a parenteral drug, buddy. Pamidronate is a parenteral drug. Also, we have one more drug which is zolendronate. Pamidronate and zolendronate. All the other drugs like alendronate, risedronate, ibandronate, all these drugs are given via per oral route. Per oral drugs, even though logically your logical brain will think that per oral drug will be there in the jaw, more chance. No, not that. Just erase that thought. The inverse is going to be true over here. Parenteral drugs tend to produce maximum osteonecrosis of jaw. Per oral drugs will produce least chances. Why am I repeating that statement is, we have seen a question asking like, which of the following drugs tend to produce maximum osteonecrosis of jaw? And we had alendronate, risedronate, ibandronate, pamidronate. The answer for that question is going to be pamidronate in that options, because that's a parenteral drug. Good, guys. Yep, zolendronate and pamidronate are given via IV route. Yep, parenteral route. You're all right, buddy. Now this is what a case of. This is a case of gum hyperplasia. This is a case of gum hyperplasia. Which drug is associated? Which drug are associated with gum hyperplasia? A very famous question, no? Of course. Recurrently is been asked in many different exams. Which drug produces gum hyperplasia? One everyone knows, no? Phenytoin. Everyone knows phenytoin, and rarely even carbamazepine also is associated with the gum hyperplasia. Apart from that, what are the other drugs which might produce? Yep, waiting for the answers. That's the question, buddy. You will not see. They will give you that image and you will never see phenytoin or carbamazepine in the option. Yeah, that's what the concept is. Which drug? Beautiful, fantastic. Nifedipine, cyclophosphamide. We'll explain that. Calcium channel blockers like dipin drugs. Calcium channel blockers like dipin agents. Yep, carbamazepine also produces gum hyperplasia, rarely when given at high doses. Good. Calcium channel blockers like dipins, like especially nifedipine on long-term usage, might produce gum hyperplasia, and immunosuppressant agents, guys. Immunosuppressant agents like cyclosporin and tacrolimus. Remember this, buddy. Cyclosporin and tacrolimus are associated with gum hyperplasia. So why am I writing this question is, of course, you will face this question, but you will never find the common answer phenytoin in the options. So what are the other options? Calcium channel blockers. If nifedipine is there, choose that. Or cyclosporin, tacrolimus is there, choose that. Which drugs are producing maximum gum hyperplasia? Moving on to the next one, a very famous question, very famous question. This is, here we can see something called as honeycomb appearance in CT lung. Honeycomb appearance in CT lung or CT chest. Yep, which will be producing honeycomb appearance, buddy? A classical thing which is seen with what condition? Classical thing seen with which condition, buddy? Honeycomb appearance. Yes, guys, come on. Bronchiectasis, good. Any other option which is associated with honeycomb appearance? something which is related to fibrosis, something which is related to fibrosis, buddy. Pulmonary fibrosis. Pulmonary fibrosis. Which drug is associated with pulmonary fibrosis? This is an important question. Which drug are associated with pulmonary fibrosis? Of course, we have our own famous mnemonic, buddy, and that mnemonic is nice babe. Nice babe. The drugs which are associated with pulmonary fibrosis. NI stands for nitrofurantoin. NI stands for nitrofurantoin. CE stands for cyclophosphamide. CE stands for cyclophosphamide. B stands for bleomycin. Yep guys, you're all right. Bleomycin, I'm getting all the answers here. Busulfan. A stands for amiodarone. A stands for amiodarone. B stands for busulfan. And E stands for ergot and its derivatives. Ergot and its derivatives. All these drugs are associated with pulmonary fibrosis, buddy. Yep. So within this ergot and its ergot derivatives, we know about ergot drugs. No, drugs name will be having ergot, ergotamine, ergotoxin, ergometrin, all the ergo will be there. But ergot derivatives, which includes bromocriptine, methysergide, cabergolide, all these drugs are associated with, all these are also associated with pulmonary fibrosis. Because we have seen a question regarding which of the following drugs are associated with interstitial or pulmonary fibrosis, and we can never see amiodarone in the option. I've seen a question where there was bromocriptine in the option, because bromocriptine being an ergot derivative might produce that. Remember this, one more point, we have one more golide, see bromocriptine, methysergide, cabergolide. Also we have one more golide called as quinagolide. Remember this. We have one more golide called as quinagolide. This quinagolide is a non-ergot drug, buddy. Quinagolide is a non-ergot derivative. It is not an ergot drug. Remember that. The name will be very similar. There is more chance of it to land up in that answer, but remember that quinagolide is a non-ergot drug. It is not an ergot derivative, which means that is not associated with pulmonary fibrosis. Good. Which drug produces this? This is like a funny thing, guys. Don't worry. You will not expect like a image-based question like that. Don't worry. The question is going to be which drug is associated with this particular vision, or to say blue vision. Which drug is associated with the blue vision? They are used in prolactinoma and Parkinson's disease. Yes, Dr. Pratyusha, you are right. Bromocriptine is used for hyperprolactinemia and Parkinson's disease. Also cabergolide. Cabergolin, both are same, buddy. Cabergolin, both are one and the same. Don't need to buy. Sildenafil, I'm getting the answers. Sildenafil, which is associated with blue vision. Ergotamine and caffeine, yeah. I remember that, good. See, ergotamine and caffeine is usually given, I'm getting the ergotamine and caffeine, why it is given together? Because caffeine tend to increase the absorption of ergot. That's the concept of it. Good, buddy. So, which drug is associated with the blue vision? Remember this, sildenafil. Also remember with this mnemonic, buddy, you know why we use sildenafil. What is the use of sildenafil? Pulmonary hypertension. Okay, think of that first. Answer that first. From pulmonary hypertension, they found it has got additional usages of used for erectile dysfunction. Sildenafil, remember blue film, blue vision. Remember that. Sildenafil, remember blue film, blue vision. I think that's the reason why it was called as blue film. I don't know, maybe. Sildenafil, why is it producing blue vision? Because of phosphodiesterase 6 inhibition. Normally, sildenafil is associated with phosphodiesterase 5 inhibition. That is the mechanism of sildenafil. But additionally, phosphodiesterase 6 inhibition is the reason for this blue color discoloration, blue vision to be seen. It will be seen for weeks together. I have seen a case report which tend to say 2 doses of sildenafil the patient has taken, and he was suffering from blue vision for the next 6 weeks. So it has got a very deeper impact. But that is not exactly seen with tadalafil. That is not exactly seen with tadalafil. Tadalafil has got less phosphodiesterase 6 inhibition, which means it has got no blue vision abnormality, will not be seen with tadalafil. Okay. I'm getting the answers like questions like ethambutol. Buddy, ethambutol, it produces optic neuritis, retrobulbar neuritis. Blue vision is typically seen with sildenafil. Is that clear? Yeah. Good then. But what is the most common adverse effect of tadalafil, buddy? What is the most common adverse effect? Here we have seen about sildenafil, right? Sildenafil produces a phosphodiesterase 6 inhibition leading on to blue discoloration, blue vision. Tadalafil, what is the most common adverse effect? Back pain. This development of back pain is not because of the reason which you are thinking about right now. The reason for back pain is phosphodiesterase 2 inhibition. Phosphodiesterase 2 inhibition. Thank you, Dr. Shivran. Phosphodiesterase 2 inhibition is the reason for back pain which is present because of tadalafil. Remember that. Sildenafil, blue vision, tadalafil, back pain. Which drug produces yellow vision, buddy? Yep, anyone? Which drug produces yellow vision? Yep, waiting for the answers. Yellow vision. Which drug produces yellow vision? I'll give you a clue. This drug name will start with D. Drug which is producing yellow vision. We used to call them as xanthopsia. It's called as xanthopsia. The drug name will start with D. Yep. I think we are running a little bit late because we started a bit late. Rifampicin, nobody. Rifampicin produces orange-red discoloration of urine. Digoxin, beautiful. The answer is digoxin. Digoxin is associated with yellow vision. Yellow vision seen with the digoxin, blue vision seen with sildenafil. Is that clear? Good then. We'll move to the next one. Of course, this is very much direct. The same image was used in one NEET exam, buddy. You can answer it very much directly. Blue discoloration of skin, also called as smurf skin appearance. Also called as smurf skin appearance. Blue discoloration of skin. Yep. Digoxin, yes guys, digoxin tend to produce yellow discoloration of yellow vision, that is xanthopsia. Smurf skin appearance is seen with amiodarone. Smurf skin appearance is seen with amiodarone. Point number 1, if you can't find amiodarone option in that, please take this point, guys. If you can't find amiodarone option there, please go with ezogabine, because ezogabine also produces blue discoloration of skin. All this discoloration is primarily because of deposition of silver crystals. Like, it's actually one important study tend to say that deposition of silver crystals tend to produce this blue discoloration. Whenever they get exposed to sun rays, their skin tone will get changed. That's the concept of it. How can we prevent that? We'll ask the patient not to get exposed to sunlight. Even though if you stop amiodarone, for example, the patient is under therapy with amiodarone and the patient has developed a blue color discoloration of skin, for how long it will be there if you stop amiodarone? Even after stoppage of amiodarone, we have seen patients who have this blue discoloration of skin to be continued for years together. So this is not adverse drug reaction which can be corrected by immediate stoppage of that drug. Remember that. Even if you stop it immediately, the skin discoloration will take years or months together to get corrected. What exactly is ezogabine? Vancomycin, yes buddy, vancomycin will produce red color discoloration of skin. Here this is blue color discoloration of skin. Ezogabine is actually a potassium channel opener which is used for epilepsy, which is an anti-epileptic drug, buddy. This is, blue man syndrome. You found out the answer, you found out the word, blue man syndrome, and that is smurf skin appearance. You know those smurfs, like small blue colored ones. Moving on to the next one, buddy. Which drug produces more chances of bilateral femur bone fractures? A very important question which can be expected in NEET exams and also in NECT exams. Which drug will produce more chances of bilateral femur bone fractures? Bilateral, not unilateral. Yep, I'm asking a question like from multi-star red color discoloration that is actually seen with vancomycin and teicoplanin body. Red person syndrome, which the name has been changed as vancomycin infusion reactions. Which is the drug associated with the bilateral femur bone fractures? I will write down the answer here. Please note it down. Teriparatide, we have come up very much close, buddy. The answer is actually bilateral femur bone fractures is seen with bisphosphonates, especially zoledronate. Bisphosphonates, especially zoledronate, tend to produce bilateral diaphyseal or epiphyseal femur bone fractures. Point number 2, increased translucency. Remember this. If a bone says there is increased translucency or bone mineral demineralization, bone demineralization is being seen. That can be seen because of bone demineralization will be seen with tenofovir. Tenofovir. So the concept of this is tenofovir tend to be producing increased translucency, bone demineralization, whereas bisphosphonates are associated with bilateral femur bone fractures. And I'm getting some questions like chronic PPI use. Chronic PPI means proton pump inhibitors. Chronic PPI use tend to produce more chances of hip bone fractures. Hip bone fractures are very much common. Most commonly, even if it is involving the femur, it is going to be most commonly unilateral. Bilateral femur bone fractures, if you come across an X-ray with the bilateral femur bone fractures, they're asking for which drug tend to produce that. You always choose with bisphosphonates. If it is going to be iliac bone fractures or unilateral bone fractures, it's going to be your proton pump inhibitors. If the translucency, the bone marrow is going to be very much increased or bone marrow is going to be decreased, translucency is going to be increased, that is going to be seen with the tenofovir. Remember these 3 major points. Also one more point is there, buddy. What if there is avascular necrosis of head of femur? Avascular necrosis of head of femur, which drug produces that? Avascular necrosis of head of femur is seen with steroid usage. Avascular necrosis of head of femur is seen with steroid use. Remember that this is also an important question. We have covered up like bone lesions associated with pharmacology. Right? Drug which might produce gout, drug-induced gout. Drugs which are associated with hyperuricemia. Hyperuricemia, remember guys, we have a mnemonic here, pen and cycle. Pen and cycle increases urine. Remember with this mnemonic. Pen and cycle increases urine. P stands for pyrazinamide. P stands for pyrazinamide. E stands for ethambutol. N stands for nicotinic acid. Yes, buddy, you're right. Chronic PPI use. Then we have steroids, which might produce avascular necrosis of head of femur. And stands for alcohol and aspirin. Cycle stands for cyclosporin. Cycle stands for cyclosporin, which is an immunosuppressant agent. Also, we have cytotoxic drugs. Cytotoxic drugs means anti-cancer drug symbol. Increases urine means diuretic agents. Increases urine means diuretic agents. Yes, buddy, you're right. Thiazides and loop diuretics. That's what we have written it in the last. Diuretics are associated with hyperuricemia. That's also one of the reasons why hypertension with gout, thiazides or any diuretics are contraindicated. Hypertension with gout, diuretics are contraindicated because this itself produces hyperuricemia. So, one more question, buddy. If a patient is diagnosed with hypertension with gout, which drug can be given? Losartan can be administered. Losartan can be administered because it has got intrinsic uric properties. Hypertension with gout, losartan can be administered, whereas hypertension with gout, diuretics are contraindicated. Pyrazinamide, ethambutol, nicotinic acid, alcohol use, aspirin, cyclosporin, anti-cancer drugs, diuretics. Please remember this. What's the treatment option for acute gout, buddy? Treatment option for acute gout. Yes, doctor, you're right. Losartan tend to produce hyperuricemia. Treatment option for acute gout, the answer is NSAID, right? Non-steroidal anti-inflammatory agents. We can use indomethacin, naproxen, brufen, many different drugs are there. But one NSAID should never be administered, and that is aspirin. Aspirin is contraindicated in a patient with acute gout. Remember that, it's an important question. Good. We'll move to the next image, buddy. What exactly is this image? What congenital anomaly is this image? What congenital anomaly is this image? NSAID is colchicine. You're right, buddy. Very good. The options are right. I'm getting an option. I'm getting a comment like the chat box is a little bit delay. See, this is a live session, buddy. So especially whenever we are using OBS software, whenever you're using that software, there will be like around 6 or 7 second delay in the video which is getting displayed. But the comments will be online, but the video which is getting displayed, we have around 5 or 6 second delay will be there. That's the reason why there's a small delay. Adjust with that. Now, which drug? Chronic gout, we can use allopurinol. You're right, Dr. Pratyusha. Chronic gout, we can use allopurinol. We have Febixostat, F-stat, a common drug which is used in practice also. Which drug produces this? I will give you what exactly is this condition. 6th and 7th cranial nerve developmental abnormality. Yep. Now I have given you what exactly is this condition. Now try to tell me which drug produces this. Abnormal development of 6th and 7th cranial nerves. Yes, my dears, come on, you can do that. It's a very important question also, even in OG. Yep, come on. Fantastic. Good, very good. The answer is actually misoprostol. Misoprostol induced Mobius syndrome. Misoprostol induced Mobius syndrome. This when given in pregnancy. Yep, you're right, PGE1 analog body. Misoprostol is associated with the Mobius syndrome, abnormal development of cranial nerve 6 and 7. Of course, we have abducens and the facial nerve. Because of it, the patients will be developing that. But most importantly, misoprostol itself can be used for it's an abortifacient agent. It might induce abortion. But if in case it is been given and the baby survives, there is more chance that the development of 6th and 7th cranial nerve is going to be abnormal. Beautiful, Dr. Pratyusha, Dr. Suresh, you're all right. And this is Mobius syndrome, buddy. What is this? An anticonvulsant drug when administered tend to produce this adverse drug reaction. Anticonvulsant drug which produces this adverse drug reaction. Anyone? Yep. Anticonvulsant drug which produces this adverse drug reaction. Yes. You want me to give a clue? You want me to give a clue, buddy? I'll give you that. This is actually an anticonvulsant agent. The drug's name will start with P. Drug's name will start with P. Yep. Okay, I will come up with the answer, buddy. This is phenytoin. Phenytoin when given via IV route. Phenytoin when given via IV route, it will produce purple color discoloration in that. That's why it is also called as purple glove syndrome. This is also called as purple glove syndrome. We used to call them as PGS, purple glove syndrome. This purple glove syndrome is seen with phenytoin. This is also called as phenytoin when given via IV route. The patients might develop that. Most importantly, if a patient is administered phenytoin via IV route and if the patient develops this purple glove syndrome, there is if we can immediately stop it. We have to immediately stop it. If we immediately stop it, we can revoke the patient back. Some patients might be needing topical nitroglycerin. Some patients might be needing topical nitroglycerin to treat this purple glove syndrome, but usually it will not be necessary. The stopping the phenytoin IV would be enough to treat this particular condition. This is purple glove syndrome. On the other hand, purple toe syndrome is seen with this is what the answer which you were giving up previously, buddy, and that is warfarin. Warfarin is a drug which is associated with purple toe syndrome. This purple toe syndrome is classically seen because of microemboli due to cholesterol. This is because of microemboli due to cholesterol. Patients might develop this purple toe syndrome, purple discoloration of toe. So we have purple toe syndrome we have seen about purple glove syndrome, and we have also seen about one more thing, black color discoloration, that is ergot-induced peripheral artery vasospasm. Good, buddy. We have only 2 more images to be explained. Here we can see the patient has developed ulcers, oral ulcers also called as buccal aphthosis. Buccal aphthosis. Remember this, guys, the most common cause of buccal aphthosis is going to be NSAID use, non-steroidal anti-inflammatory drug use. Also, we have anticholinergic agents, antibiotics, and one more drug which is a famous one, nicorandil. This image is actually a patient who presented with nicorandil-induced buccal aphthosis. It is not clearly or direct away buccal aphthosis, buddy. We can also call it as GI ulceration. GI ulceration is most commonly seen with that. Yes, doctors, now I think there is some delay with the chat box. Now all the chats are getting loaded. Yes, phenytoin, good. Warfarin, toe is warfarin, you're right, Dr. Suresh. Dr. Hari, NSAID-induced aphthosis, you're all right. NSAIDs tend to produce more chances of GI ulceration. Also seen with anticholinergics, because anticholinergics will decrease the salivary secretion. Superadded, dry mouth will produce ulcers in those areas. And we have antibiotics. Nicorandil, this is a famous question, a potassium channel opener which is associated with buccal aphthosis. Nicorandil has got 2 different mechanisms. One is it is a potassium channel opener, and it is also a nitric oxide donor agent. It has got 2 mechanisms, guys. Remember this, nicorandil has got 2 mechanisms, potassium channel opener and a nitric oxide donor. Good. Moving on to the last image. With this, when you will end up in this first image, what exactly is this first image? Here we can see discolorations. Yeah, we can see discolorations throughout the skin, bleeding spots throughout the skin, bruising. A drug which on chronic therapy might produce bruising. And remember that this bruising will not only be seen when you wear Nike shoes. It will be seen with any shoes or any chappals. Even if you don't wear any slippers, we can expect bruising to be developed. Which drug produces this? Bruising. Long-standing use. The same drug which is associated with this condition also. This is so direct. Many times it has been asked previously. Yep, anyone, buddy? Valproate, no, guys. Valproate is associated with hyperammonemia. Bruising will not be seen there. The same drug produces both of these adverse drug reactions, bruising, and I will give you what exactly the second image body, oropharyngeal candidiasis. Used in chronic angina nicarandal, yes buddy, you're right. Fluconazole, no, because fluconazole will not produce this. For oropharyngeal candidiasis, I cannot use fluconazole also because fluconazole will not be accumulated in your mucous membranes. We need clotrimazole there. Aspirin, no, it will not produce that buddy. Aspirin might be associated with Ray's syndrome. Ray's syndrome is different. Here I am talking about bruising. Bruising and oropharyngeal candidiasis can be seen with inhalational steroids. Yeah, I can hear you saying, yeah, oh my God. Inhalational steroids tend to produce, yep, you're right, daughters, steroids, you're right. Inhalational steroids tend to produce oropharyngeal candidiasis, especially when given in PMDI forms. What is PMDI? Pressurized metered dose inhaler. Beta-methoxone, beautiful, you're right. Pressurized metered dose inhaler. You know that pressurized metered dose inhaler is there, no? Whenever you just put up in your mouth and you just purse your lips and you just press it, majority of the drug will be just, because of the force, majority of the drug will be deposited in your pharynx. Only minimal is going to be inhaled. That will be enough for bronchodilation. But what about those drugs which has got deposited in your pharynx? Locally immunosuppressive property, superadded fungal infections, leading on to oropharyngeal candidiasis. On long-term usages, it is also associated with the bruising, which is a recent adverse drug reaction, which has been found out with the long-term usages of steroids. Because previously, we don't find many of the patients who are put under long-term therapy with steroids, inhalation steroids. But post-2019 GINA guidelines, steroids with the long-acting beta-2 agonistic agent is the treatment option currently as first-line therapy. So now lots of patients are currently using long-term steroid inhalations, and they are more prone to land up in bruising also. Now comes the most important question, buddy. Yep, now comes the most important question. Which is the drug of choice for this oropharyngeal candidiasis? Drug of choice for this oropharyngeal candidiasis? Yep. This is not a fluconazole. I can use clotrimazole. For candida infections, I can use fluconazole. Yes, candida infections, fluconazole. But fluconazole cannot be given in these conditions because fluconazole attains minimum concentration in the mucosa. So we have to give clotrimazole for this patient. How can it be prevented, buddy? How can it be prevented? Point number one, I can use something called as spacers. Spacers are just big apparatus-like kind of things, buddy. We'll just fix that pressurized metered dose in here on the other end. The other end will be put up in this mouth. Once I press it, drug will be dispersed in this small gap, and I just slowly inhale that. Drug will gain entry inside the lungs, minimal deposition in the pharynx. That's the concept of prevention of oropharyngeal candidiasis. Also, whenever we take a pressurized metered dose inhaler, you just press that, drug will get deposited there. Immediately after doing that, you go with gargling. Yep, you're right, gargling. Gargling can be given, and nystatin, of course, guys, we can also use nystatin in these conditions. Clotrimosoles or nystatin can be administered. If clotrimazole is not there in the option, then we can opt for nystatin there. So spacers, and we can opt for gargling, because gargling, with this we can prevent the drug which is getting deposited over there. These are the different images, especially which is important for your exams, guys. So I think we have discussed major images and some rarer adverse drug reactions and newer adverse drug reactions. I hope I have just helped you with a lot of new points, buddy. You just store this video. Please try to make sure you recurrently see these videos even before the exams. That will be very much useful for you. Please remember one important point. We are here to win. We're not here to participate. We are here to win. Thank you.